should count. Well, welcome to Grand Cayman. We know some folks have had some challenges with this polar vortex and this winter storm Fern, but we're glad you're here, and we're going to have a full in-person session starting tomorrow morning, as per usual. This is just a Zoom session that we have this evening to enable people to get some extra hours of credit, and et cetera. So this is a purely Zoom session. We will be live streaming and recording the entire session so that you'll have access to this either while you're here and also afterwards. So we have two sessions this afternoon that start us off. And the first is Justin Richards from University of Maryland and Maryland Shock Trauma. I have an adjunct faculty appointment at the University of Miami, and he came down to visit. I don't know, Justin was at almost a year ago, probably now that he came down, gave a fantastic presentation on trauma resuscitation, and I thought it would be great if he could share it with us today. So, Justin, if you want to go ahead and share your screen, and we'll take it away.
Wonderful. Well, thank you so much, Dr. Ellis, for inviting me to do this. It's a great pleasure to get to be a part of it. I love talking about this topic. And thank you to y'all who are logged in and participating in this conference. I've heard great comments about it, and again, really glad and privileged to get to be a part of it with y'all today. As Dr. Ellis mentioned, I'm an anesthesiologist at the R. Adams Cowley Shock Trauma Center in Baltimore and at the University of Maryland. And I have no financial conflicts of interest related to this topic. And I'll tell you that at least right now, as Dr. Ellis mentioned, there's the winter storm, but I've also realized there are actually a lot of similarities, believe it or not, right now between where y'all are in Grand Cayman and Baltimore. Woke up this morning and it was really sunny, so we have that in common. The temperature was about 10 to 15 degrees. Now, for y'all, it's 10 to 15 degrees, probably Celsius. Here, it was actually 10 to 15 degrees Fahrenheit. And I would also imagine many of y'all are surrounded by ice in the Grand Caymans. Hopefully, it's ice in your drinks. For here, it's ice all over our roads. Yet, I hope y'all are enjoying the time that you're going to have in Grand Cayman. So to kind of get to really what this talk is going to be about, and I'll really give you the punchline from the very start, a little bit of a spoiler alert. In dealing with the management of hemorrhagic shock, and as the title describes, traumatic hemorrhagic shock, we'll talk a little bit about the end if some of these concepts are extrapolated and can be extrapolated to non-traumatic hemorrhage. Yet really where we are, I think, in now the beginning of 2026 with management and resuscitation of early hemorrhagic shock is it's a plasma-based resuscitation. We want to minimize crystalloid, and we want to give early tranexamic acid. And again, this is kind of damage control resuscitation, as the phrase goes, with early traumatic hemorrhage. And a lot of this really will be organized, this next hour organized around discussing the foundations of traumatic hemorrhage resuscitation. Can we extrapolate this to non-traumatic hemorrhage, and where are we going in the future with some potential future ideas? So really, when we talk about hemorrhage, and whenever I discuss this with our trainees, I mention to them really the importance of hemorrhage is being able to recognize it. And that's why we have these massive transfusion events. And that's what I'll refer to over the next few minutes, perhaps massive confusion events, because we have so many different terms to describe whether it's massive transfusion, massive resuscitation. Are these massive transfusion protocols or events? Is it coolers of blood? What's the ratio of blood? Does the ratio matter? Do you have to give the entire cooler of blood? So there's a lot of confusion when it comes to some of these massive transfusion events. Yet the important part is recognizing when patients are going to need and should be receiving early blood products. And when this concept of massive transfusion protocols was really first described now more than 15 years ago, the whole purpose was to acknowledge a process that was multidisciplinary. And this involves the blood bank, it involves trauma surgeons, anesthesiologists, anesthetists, It involves nursing staff. It involves volunteers or the runners who are going to get blood products. It involves the nursing staff in the operating room to continue to send for these blood products. So this is really emphasizing a multidisciplinary process so that everyone who's involved in the care of these patients, for which it can be really complicated, are aware of the timeliness and the importance of these events. And again, the whole idea is that time matters. Really, minutes matter in these patients and getting blood products, not just red blood cells, but red blood cells, plasma, platelets, potentially other blood products. Getting these blood products to patients very quickly is very important. And I like showing this next figure to demonstrate why time matters in these patients. This is a figure from the proper trial, which is now more than 15 years old. And it was really one of the seminal trials, at least in terms of traumatic hemorrhage, which asked the question of does the ratio of packed red blood cells, plasma, and platelets impact mortality? And for all practical purposes, this was a negative study. And it showed that there was no difference in 28-day, 30-day mortality with regard to the ratio of blood products. There were some secondary outcomes that were observed. Most notably, time to correction of hemorrhage and death due to hemorrhage was a little bit lower in those patients who received higher ratios of plasma. Yet what this figure, I think, really demonstrates is how early these patients are dying. This is a survival curve showing in terms of hours, out to 24 hours, that while there was no difference in mortality at these time points, patients were dying really quickly. And the linear relationship of mortality and time was quite linear and quite noticeable up to about 3 to 4 hours. After that time point, at around 6 hours beyond, the mortality really stayed fairly flat. So when these patients are dying, they're dying very early, within hours, if not within minutes. Is another survival curve from a study that subsequently was published a few years later, and we'll talk about this in a moment in terms of specific blood products. Yet this demonstrates that whether you're giving early plasma or standard of care, whether it's crystalloid or packed red blood cells, these patients are dying very quickly, and most of them are dying within the first 24, if not 48 hours. Yet that linear relationship with mortality is occurring within the first 3 to 4 hours. And we've observed this in multiple studies. Most trauma patients are dying of hemorrhage within the first few hours. And this was the case in that proper trial. The time death due to hemorrhage, the average time due to death due to hemorrhage was about an hour and a half. And another subsequent observational study, this just looking at trauma patients with traumatic brain injury and hemorrhage, or simply hemorrhage, yet the average time due to hemorrhage was about 2 hours. So as I mentioned, these patients are dying within the first couple hours. Time matters. Such that even more recently, there's been a big push to kind of define important outcomes in bleeding trauma patients as not being 24-hour or 28-day mortality, rather 6-hour mortality. So the interventions we can do within a short period of time, we think are very important. And so another concept that I like to discuss, certainly with our trainees, whenever I talk about hemorrhage, is that how do we identify these patients with hemorrhage? And certainly those folks who have been doing this for a long period of time, I think, have a very good gestalt and say, I know when I see it. The patients who are bleeding, it's quite obvious because they're sick. Yet the statement I make to that is they look sick because they are sick. And in fact, this is a self-fulfilling prophecy in that the patients who need early intervention look obvious because in fact they need the intervention. Yet our whole goal is to be able to identify who these patients are as soon as possible because time matters. Hours and minutes matter. And so there are a lot of different scoring systems to identify massive resuscitation, bleeding from resuscitation. And many of y'all probably have massive transfusion protocols or massive transfusion events or ways to activate large volume resuscitation. And again, to communicate to the blood bank that you need a lot of blood product. And there's no one right scoring system. The right scoring system is the scoring system that works best in your institution and within the logistics that you have at your institution. Whether that's a massive transfusion score, an ABC score, a bleeding risk score, every place is a little bit different. And for us at Shock Trauma, we have our own kind of massive transfusion indications, which very closely follow this ABC score. And that's one of the most commonly described scoring systems. And for me, it's fairly simple to remember because it involves four components. And that's hypotension, a systolic blood pressure of less than 90, tachycardia, a heart rate greater than 120, a positive focused assessment of sonography and trauma, or a FAST score, looking with an ultrasound for some type of fluid in the abdomen, and then also penetrating trauma. Any two of those criteria are really good at being able to rule out patients who are bleeding, such that any two of those criteria is going to be able to potentially activate a massive resuscitation. And in using that resuscitation score, this one study a few years ago commented that whether using physician judgment or an ABC score, the physician judgment was really good at being able to identify those patients who are going to receive a large volume transfusion. And while our physician judgment is really good, if we use these scoring systems, such as the ABC score, most of these patients are going to be identified in the emergency department. Whereas if we're using physician judgment, a lot of times it's happening in the operating room. Sometimes that can be a 30-minute, hour delay. And if most of these patients are dying within 2 hours, those 30 minutes to an hour can make a big difference. So while massive transfusion and massive resuscitation is a fairly infrequent event when it comes to trauma patients, it's about a single-digit percent. Our ability, again, our inherent physician ability to be able to predict massive transfusion, as I mentioned, was pretty good. One study showed they were able to do that about 75% of the time, that physician judgment was able to accurately identify large volume resuscitation. However, as I mentioned, most of the time this was occurring in the operating room. Had they actually applied some type of scoring system to these patients to predict large volume resuscitation, this would have happened in the emergency department in over 80% of patients. So back again, emphasizing the why time matters. And that's the purpose for these scoring systems. We want to communicate to the blood bank. We want to communicate to the nursing staff. We want to communicate among ourselves. We're using a lot of resources, and we want to identify who these patients are who are going to need these resources as soon as possible. And so, as I mentioned, time matters. Hours matter, yet every minute matters. This was another kind of secondary analysis from that proper trial that I mentioned a few moments ago, really looking at how long it took to deliver blood products to these patients who were receiving massive transfusion. And for every minute delay in delivering blood products to the patient, there was a 5% increase in mortality. And so I'll re-emphasize, time matters in recognizing hemorrhage, time matters in managing hemorrhage. So I'll re-emphasize the time matters part. So once we identify who these patients are as quickly as possible, yes, our goal is to give them essentially what is coming out of them, which is something red. And that's why a lot of times we're going to be giving them packed red blood cells. And I mentioned a moment ago with that proper trial, the ratio of blood products to plasma really didn't matter in that study, yet there was a little bit of a caveat. And that's that all patients were getting early plasma, whether it was in the intervention group or the control group, patients were getting early plasma. And what we've subsequently learned from a prospective multi-center randomized trial is that early plasma, and this was specifically done on a helicopter, but those patients who were being transported by helicopter to a trauma center and were at high risk of bleeding, if they got upfront 2 units of plasma, their 28-day mortality was significantly lower compared to those patients who got no early plasma. They either got crystalloid or packed red blood cells. Now, again, these patients were transported via helicopter, so it was a little bit longer pre-hospital transport time. They may have had a little bit different pre-hospital care, especially on an aeromedical transport as opposed to an ambulance. And these were also predominantly blunt trauma patients. Yet what we observed and what's really kind of, I think, impacted our care over the last 5 to 10 years is not only is early plasma, we know it's helpful, yet it's probably decreasing mortality. And even in subgroups of patients, as I mentioned, this study looked at predominantly blunt trauma because those were the patients most likely to be transported on a helicopter. Yet when they looked at those patients who got less than 10 units of red cells within 24 hours, there was a big benefit of that early plasma. There was also a very markedly observed benefit of early plasma reducing mortality in those patients with traumatic brain injury. Again, a very important population because most of our trauma patients are blunt patients at high risk of traumatic brain injury. And so The differences in mechanisms, potentially the differences in pre-hospital transport were quite interesting. Yet, I think what this study really showed us is that emphasis on early plasma. Proper showed us that we were very good at getting early plasma. What this study showed was that early plasma, especially pre-hospital plasma, seemed to be making a difference in mortality. And this was a 10% difference in mortality when they looked at patients overall, which is a big difference in mortality when we look at patients who are critically ill. And as I mentioned, where we were starting to kind of see why this benefit in plasma was most apparent and where it was most apparent was the blunt mechanism, those who had a little bit longer pre-hospital transport time, those who came from the scene of injury as opposed to being transferred from an outside facility, and those receiving kind of a moderate amount of packed red blood cells. And one of the reasons I suspect that this group that was receiving somewhere between 4 to 7 units of packed red blood cells were benefiting from the early plasma is because I don't think a coagulopathy was always going to be present in these patients. I think by getting that early plasma, we're able to help some parts of the blood vessels that I'll talk about in a quick moment. Yet we were potentially not getting into the really bad coagulopathy in these patients with a moderate transfusion. Once we start talking about coagulopathy, that's a very different topic. Um, and inherently, plasma itself is not going to fix a coagulopathy. That's why I think coagulopathy is very important, yet oftentimes it's a very different management than just strictly managing hemorrhage. And so one of the benefits that we suspect is attributed because of this early plasma-based resuscitation is what plasma is doing to the blood vessels themselves. And as one of my Australian colleagues kind of describes, that plasma seems to hug the blood vessels. You've got these blood vessels that with shock and tissue damage are quite disturbed. The glycocalyx has been disrupted. The blood vessels are dilated. The blood vessels are not the healthy, plump cuboidal cells that we normally see. And so this plasma seems to kind of restore those blood vessels and give them a nice hug, for lack of a better phrase. And what we've observed is that when you have shock, as I mentioned, there's a significant and substantially noticeable damage to the inside of blood vessels. And when we give early plasma, the damage to the blood vessels, the markers that show a damage to the blood vessels, are significantly lower in those patients that get that early plasma. So this is one of the suspected theories of why plasma is so helpful. Plasma doesn't have oxygen carrying capacity. It's got a lot of proteins. Some of those proteins are coagulation factors, yet the reality is you have to give a lot of plasma to help support coagulation factors. So I don't think plasma is helping coagulation. I think it's helping to really restore the inside of those blood vessels. And one of my surgical colleagues back more than 10 years ago now did a really nice animal study showing what happens to the inside of blood vessels in an animal model of hemorrhage. And what Rosemary Kozar showed was on the far left, this is a normal pulmonary blood vessel in a rat. And you can notice the inside of that blood vessel and that endothelial glycocalyx, these are very plump, kind of round, healthy appearing cells. The next image to the right of that figure A, the next image is a blood vessel that was exposed to hemorrhage. The inside of that glycocalyx is completely destroyed. It's no longer present. And in fact, the blood vessels themselves are now very thin with some junctions and space in between the cells. When you give crystalloid to patients who had hemorrhage, not much is really changing on the inside of the blood vessel, which is why, as we're going to talk about in a moment, we try and minimize crystalloid. Crystalloid is not helping the inside of the blood vessels. Yet in these animals that were exposed to hemorrhage and then given plasma, the inside of the blood vessel started to change. And it looked like some of that endothelium was starting to be restored. And that's, again, the suspicion for why there's the benefit of early plasma is that it's helping to help, again, restore the inside of the blood vessel and help regenerate that endothelium. So we've talked about identifying hemorrhage as early as possible. We've talked about getting blood products and initiating massive resuscitation as early as possible and doing that early with plasma. And really what this also involves is minimizing crystalloid. Now, as Dr. Ellis mentioned, I gave a very similar talk down in Miami at the University of Miami about a year and a half ago. And part of my history is that I was born in Miami. I've always been a Miami sports fan. So I show this picture of Nick Saban when he was the coach of the Miami Dolphins. which seems to be fairly obvious. Well, yeah, we should be giving less crystalloid, but sometimes it's not that easy, especially when crystalloid might be all that we have. Yet I'll kind of get to, I think this is where it's a little difficult. We still should be kind of withholding that urge to give volume if it's only crystalloid, because crystalloid is not really helping us. Now, in order to talk about minimizing crystalloid, the next topic that comes to mind is, well, what about permissive hypotension? Surely this is good, and that minimizing blood pressure, allowing a lower blood pressure in patients who are bleeding, must be good. And there was a review, meta-analysis, more or less, over 5 years ago, closer to seven, um, showing that ultimately their conclusions being permissive hypotension may offer a survival benefit over conventional resuscitations in patients with hemorrhagic injury. Those were literally the words in the conclusion. And yet it goes on to say at the very end of the conclusion, however, a majority of these studies were underpowered. And that's why I think this concept of permissive hypotension, especially in traumatic hemorrhage, is misunderstood and potentially miscommunicated. And I want to give you some evidence as to why, and then we'll talk about, well, what can we do as far as blood pressure, especially if we don't have any blood products and all we have is crystalloid. Well, there were a number of studies looking at this concept of permissive hypotension, and many of us probably remember, again, whether we're doing open vascular operations, spine operations, and a lot of times with hemorrhage, at least in the United States and North America, there has been a big push for permissive hypotension with hemorrhage. And this is because of a number of studies, prospective randomized studies, which have looked at this topic. Really, what they've done in terms of trying to control blood pressure in patients who are bleeding was actually give crystalloid or not give crystalloid. And I want to show you, at least as far as numbers, and were we actually able to achieve a desired blood pressure in these patients? The first study, this was kind of the seminal study looking at traumatic hemorrhage. It was in the New England Journal of Medicine over 30 years ago. And they showed that the blood pressure in those patients who got early crystalloid was significantly higher in those patients who got no crystalloid. And the mortality was better in those patients who got no crystalloid. So the conclusion was, well, permissive hypotension is good and beneficial because the systolic blood pressure was lower in those patients who survived. Well, the reality, I think, is there's not much of a clinically significant difference between a systolic blood pressure of 79 and a systolic blood pressure of 72. Furthermore, the intervention in this study was not blood pressure. The intervention was not giving crystalloid. So those patients who survived actually got less crystalloid. Another subsequent study was done a few years later, this one actually at shock trauma, looking at permissive hypotension and trying to achieve a systolic blood pressure of around 70 or greater in patients who were bleeding. Really, what ended up happening is there was no difference in mortality in either the intervention group or the control group. And actually, the blood pressures, even though they wanted it to be 70 in the intervention group, was closer to 100. And while this was statistically significant, again, I would suggest that there's likely not a clinically significant difference between a systolic blood pressure of 114 or a systolic blood pressure of 100. So this is one example of we might want the blood pressure to be lower, yet the patient might not want it to be lower, and the patient's going to do what the patient wants to do. A few subsequent studies, again, now prospective randomized multi-center trials, these within the last 10 years or so, showing very similar results. And that while we want a blood pressure to be a certain number in trauma patients, they're not wanting to do that. And in fact, both these studies by Schreiber and Carrick showed that while they wanted the systolic or the mean arterial pressure to be 70 or 110, it was in fact closer to 100 in the intervention group. Same in this bottom study by Carrick. While they wanted the mean arterial pressure to be around 50, it was in fact 65. So we're showing that it's really hard to achieve a specific blood pressure. The patient's going to do what the patient wants to do. And really what we're seeing is while there's no difference in mortality in any of these studies, other than the Bickel trial, which was not a blood pressure trial, it was a crystalloid or no crystalloid trial. Really what we're doing is giving less crystalloid. And in all of these trials, even though the blood pressure is not necessarily any different or we can't achieve the desired blood pressure, we're giving less crystalloid. And more recently, what we've seen is we can give less crystalloid, the blood pressure is still going to be okay, and there's no difference in mortality. So really, this idea of permissive hypotension is we can give less crystalloid. What was concerning in thinking about this topic and really kind of considering this topic, especially in the most recent trial by Carrick and colleagues, is they stopped the trial early. They said we weren't actually able to achieve our desired blood pressure goal. And in their discussion, they said it's theoretically possible that the anesthesiology team did not perform the intervention as intended. And this really caught my attention. And I think for us as anesthetists, it should catch our attention with regard to our role in the resuscitation. And that I wanted to sit here and ask the trauma surgeons who wrote this study, you really think the idea that you couldn't achieve the goal and you couldn't achieve the blood pressure was because of anesthesia? We've never been able to achieve this. It's not anesthesia's fault. The reality is it's our choice of how we're choosing to resuscitate these people, blood products and minimizing crystalloid. And so, with all this, I come away with the opinion, and opinion based on some of this data, that really permissive hypotension, I think it might be a great idea, but we've actually never been able to achieve it in a lot of clinical studies, and I'm not sure it exists. What does exist is we can give less crystalloid. Now, I want to show why I think blood pressure and permissive hypotension has been greatly misunderstood and potentially miscommunicated, is because more recent work, now this looking at early blood product resuscitation and specifically pre-hospital blood products. This was retrospective. It was a single center study done in New Orleans, predominantly penetrating trauma. And what was observed is those patients who had penetrating trauma, who received early pre-hospital packed red blood cells, in fact, had an improved mortality. Yet, what was also observed is that when they got pre-hospital blood, when they arrived at the emergency department, their systolic blood pressure was statistically and I think clinically significantly higher. And again, these were the patients who had lower mortality. And I think we're going to start to see now with more early blood products that the blood pressure is higher and these patients are actually surviving. Not necessarily because the blood pressure is higher, I think because they're getting early blood products. And so this kind of led to an idea that before I pulled this talk together a few years ago, talking about our methods of resuscitation and permissive hypotension. One of my colleagues who's in the military said it's not really permissive hypotensive resuscitation, yet rather progressive resuscitation. We give the patient what they need when they need it with what we have. And I think that's an important concept of progressive resuscitation. So we've talked about now blood products and early blood products, early plasma, minimizing crystalloid. Well, what if you don't have blood products? And if blood pressure doesn't matter, what about vasopressors? Can we try and at least get a blood pressure a little bit higher by using vasopressors, especially if all we have is crystalloid? And I'll say this is kind of a controversial topic, certainly in North American trauma systems, because vasopressors historically have always been associated with increased mortality. We've been told that vasopressors are contraindicated in trauma patients. There's a lot of data that supports this. Now, these studies that I mentioned here saying that vasopressors increased mortality had a lot of limitations. They were all retrospective. They included all vasopressors, phenylephrine, epinephrine, norepinephrine, dopamine, and vasopressin. And we all know that all those vasopressors do not work the same way. I think very interestingly and importantly, a number of these studies actually also excluded patients that died within 24 hours. Think back to what we first started talking about. Most trauma patients who are bleeding are going to die within the first few hours. So I think one of the conclusions about vasopressors being bad in trauma patients, and we shouldn't give vasopressors to patients who are bleeding, didn't really even look at patients who were bleeding and likely to die. So I think there were a lot of limitations to this.
Justin, let me just ask you a question before you go further. Do you want me to put up a poll about this, or is that later, or you tell me?
Well, let's do that later because I've got the questions kind of afterwards as far as the poll.
Perfect, thank you.
And yep, and so I think I'm very curious to see how folks would approach this, how you potentially would approach it. I'd love to hear how folks would approach this, last week, how they might approach it now. Is there a difference? Maybe there's not a difference. A lot of it actually comes down to what you have access to in your resources. And so kind of talking about vasopressors, we know that all vasopressors aren't the same. And one vasopressor in particular that I think is very interesting is vasopressin. And we know that in patients who are critically ill, specifically septic shock, patients have a vasopressin deficiency. And we've observed the same in patients with hemorrhage. And a prospective randomized study, albeit single center, this was done at University of Pennsylvania a few years ago, looked at patients who were receiving a massive resuscitation, and they gave them a vasopressin infusion during their resuscitation and for 48 hours afterwards. And they left the vasopressin infusion really at 0.04 units per minute. They were titrating it a little bit, but there was a very tight window of a vasopressin infusion. One of the reasons why I love vasopressin is because I just let it run. We're really trying to support a vasopressin deficiency, and I leave the rate really at a single dose, which was more or less what was done in this trial. And while they observed there was no difference in mortality, one of the big significant differences they observed was the total amount of blood product. We know that over-resuscitation in patients is bad, and that can lead to pulmonary complications, cardiovascular overload. And so if we can minimize the amount of overall volume that we're giving patients, perhaps that's a good thing, especially from an organ failure standpoint. And that's what happened in those patients who received vasopressin, is they got less blood product. Granted, there was no difference in crystalloid, yet I would also point your attention to in 48 hours, these patients were giving 10 liters of crystalloid. That's a lot of crystalloid. So I think vasopressin is really valuable in bleeding trauma patients. I try and use it in any patient who's receiving a massive resuscitation. And again, I just leave that infusion, have them go up to the ICU if they're going to the ICU, and tell the ICU, just leave the infusion. Don't worry about their blood pressure. Keep them comfortable, support their organ systems, and we're supporting a vasopressin deficiency when we give these patients vasopressin with hemorrhage. Well, what about tranexamic acid? I think this is something we're all very familiar with using, especially if we're dealing with larger orthopedic spine operations, potentially liver transplant, obstetric hemorrhage. This has been a very widely discussed topic in trauma patients, bleeding trauma patients. The data on it seems to be a little contradictory, yet I want to at least explain to you why I think tranexamic acid is very helpful in trauma and what the data really shows when we look at the numbers. There are three big prospective randomized studies, at least in trauma patients with hemorrhage, using tranexamic acid. The first of these came out a little more than 15 years ago, and that was the CRASH-2 trial, and that's what generated a lot of enthusiasm for using tranexamic acid. This was dealing with 20,000 patients. It was a prospective randomized multi-center international trial, and they observed a statistically and clinically significant, I think, difference in patients who received early tranexamic acid. The next study, the STAMP trial, this was again prospective randomized, giving pre-hospital tranexamic acid. And this was done in the United States, and they observed no difference in 30-day mortality. And I'm going to show you why I think they observed no statistically significant difference, yet why this is a really important study. More recently, a few years ago, another prospective multi-center randomized trial looking at bleeding patients who received early tranexamic acid, and there was a lower 28-day mortality. Yet what I want to show you is in each of these studies, if you look at their outcomes, the relative risk or the hazard ratio, in the CRASH-2, the STAMP trial, and the patch trauma trial was all very similar, somewhere around 0.8. And this was really consistent. Granted, these were done in different countries, different patients, other than having the common features of patients at risk for bleeding, yet done in very different environments. Yet the results and the numbers that we were seeing were very, very, very similar. And I think this is where at least the benefit of tranexamic acid lies, in that we're seeing consistent results when it's given to patients who are at risk for bleeding really early. And so it's controversial because the results are not statistically different with that STAMP trial, yet the reality was it was underpowered to show a difference. The hazard ratio, very, very, very similar, I emphasize. Yet they just didn't have enough patients to make that a statistically significant result. Now, we think about tranexamic acid as being a plasminogen inhibitor. It inhibits the conversion of plasminogen to plasmin, which causes a clot to break down. Yet I actually think it might be doing something a little different. Very similar to early plasma, I actually think tranexamic acid, and the hypothesis is that early tranexamic acid might be helping to restore that endothelial glycocalyx and to help kind of protect the inside of the blood vessels. And this has been shown with some secondary work, some really retrospective work looking at prospective data. Yet again, the amount of blood vessel damage that was occurring in patients who received tranexamic acid was significantly less in those patients who did not get early tranexamic acid. So we think there's potentially an anti-inflammatory effect. and again, some helping to restore the inside of the blood vessels in those patients with hemorrhage when they get early tranexamic acid. So can we extrapolate some of this? Again, early recognition of hemorrhage, early plasma, early tranexamic acid outside of hemorrhage. And so I at least want to show you some data that exists looking at non-traumatic hemorrhage in those patients who got a massive transfusion compared to those patients who didn't get a massive transfusion protocol. Now, I mentioned a few moments ago at the very beginning that our definition of a massive transfusion protocol is quite variable. And all of these studies that were done in non-trauma patients were in fact retrospective. So there's a big limitation. We don't know why they were getting the blood products that they were getting. We don't know why they were getting certain ratios. Now, there seemed to be at least a favorable 24-hour mortality benefit in those patients who got early massive transfusion. And whether or not that's the early plasma or because this was retrospective, were they just actually receiving better hemorrhage control? That's what stops hemorrhage, is hemorrhage control. We don't know. And that's one of the limitations. My conclusion and what I take away from this is if we can get early blood products to patients, they're certainly going to do better in the short term. And I think if we're giving them a couple units of packed red blood cells, we should also be thinking about some plasma. I think there's definitely a benefit of plasma, especially compared to crystalloid. And I'll reemphasize, I think what we're seeing is we're giving patients potentially less crystalloid. And that's a big emphasis in hemorrhage. Give patients as little crystalloid as possible. Now, another study, this one looking at massive transfusion protocols in patients with non-traumatic hemorrhage, again, retrospective. So we don't know what the ratios were, why they were getting the ratios of packed red blood cells and plasma, but really showed no difference in mortality. And I'll reemphasize that this was retrospective. We don't know why patients were getting the ratios that were being observed. So there's limitations to the data. If we're really looking at there's no benefit of early massive transfusion in non-traumatic hemorrhage, I think we have to recognize we need to get blood products to patients who are bleeding, and we need to do that as fast as possible. I don't know the exact ratio. I don't know if every patient needs plasma, and I know we should be minimizing crystalloid, and we need to get the blood products there as quickly as possible. So another retrospective study, again, just emphasizing how limited the data is. This was in anesthesia and analgesia a little over a year ago. And it looked at the plasma to red blood cell ratio, and they observed an increased risk of mortality, an increased risk of pulmonary embolism, an increased risk of DVT. I emphasize these were patients who had non-traumatic hemorrhage, yet this was retrospective. We don't know when they were getting blood. We don't know why they were getting the ratios they were receiving. We don't know anything about the early mortality. And so I think, again, recognizing that, yes, there are limitations to the data, and that's because this is a very heterogeneous group of patients. Well, can we extrapolate the idea of early vasopressors, and specifically early vasopressin in patients with non-traumatic hemorrhage? And I'll be honest, there's very limited data looking at early vasopressin outside of traumatic hemorrhage. We're actually involved in an observational trial. This is a large observational trial, simply looking at phenylephrine versus norepinephrine and not even vasopressin. Yet there's so much that we still don't know about early vasopressor use in patients undergoing an anesthetic that we'll know a whole lot more, I think, in the next 3 to 5 years. Yet what we had observed in a lot of this enhanced recovery after surgery protocols, which are trying to minimize excessive crystalloid, trying to focus on minimizing opioids and also giving early vasopressors, that we saw there was an increased risk of acute kidney injury. And my suspicion with this is we weren't actually treating the patient, we were treating a protocol. And I think a lot of patients who are undergoing non-emergent operations can tolerate a certain amount of crystalloid. Each patient needs a different blood pressure. There's not a magic blood pressure for one patient. So the idea that we go to early vasopressors in every patient to achieve a certain mean arterial pressure, I think might be a little premature because each patient ends up being a little bit different. The patient's going to do what the patient's going to want to do. And a little bit of crystalloid during an anesthetic is not bad. Liters and liters and liters of crystalloid in patients who are bleeding is not going to help the blood vessels and certainly doesn't correct the bleeding. Well, what about tranexamic acid in non-traumatic hemorrhage? I mean, we have a decent amount of data, yet a lot of it is retrospective. I mentioned one in particular because this is a really important patient population, and those patients with gastrointestinal hemorrhage. There are some differences, some similarities with massive bleeding, with traumatic hemorrhage, and with gastrointestinal hemorrhage. It can be a lot of bleeding. These patients can be critically ill with organ system dysfunction. However, there are also some differences. With gastrointestinal bleeding, we don't know when the bleeding happened. And I think that's one of the big differences of why in this specific study there was no observed benefit of early tranexamic acid, or excuse me, of tranexamic acid in general. And that's because we don't know when the bleeding occurred. We don't know if the tranexamic acid actually got to patients early. The benefit of tranexamic acid in trauma patients is giving it within 3 hours of injury and potentially even earlier within an hour of injury. So there's definitely a time window where there's a benefit of TXA. Within 3 hours of injury, absolutely within trauma patients. We don't know when bleeding happened in gastrointestinal hemorrhage, and I wonder if part of this increased risk of poor outcomes, whether it's mortality or thromboembolic events, is because a lot of these patients were getting TXA outside the beneficial window because we don't know when gastrointestinal hemorrhage actually started. Same with liver transplant. It's a little bit more of a controlled environment. This was a retrospective study showing no difference in blood loss in patients who got TXA. Yet I emphasize that we don't know when the bleeding was actually occurring. And we don't know why these patients got TXA or didn't get TXA because this was retrospective. Now, another very important population, especially when it comes to hemorrhage, and one where I think there's some similarities with traumatic hemorrhage and potentially the benefit of tranexamic acid, and that's postpartum hemorrhage. We've got a number of prospective randomized studies looking at early tranexamic acid in patients with postpartum hemorrhage, again, whether it was via cesarean delivery or vaginal delivery. And this first study showed that there was a significantly lower risk of increased blood loss in those patients who, or excuse me, there was no difference. I misquoted there. No difference in postpartum blood loss in those patients who had a vaginal delivery compared to a significantly lower risk of increased blood loss in those patients who had a cesarean delivery. Now, the reason for this, I suspect, is related to the fact that in a cesarean delivery, and specifically a scheduled cesarean delivery where there was the biggest benefit observed, we know when the bleeding occurred. It happened at the time of the scheduled cesarean delivery. We don't know when blood loss was occurring in a vaginal delivery or in an emergent cesarean delivery. Another feature I want to bring y'all's attention to, especially when it comes to the benefit of tranexamic acid in postpartum hemorrhage, is look at the relative risk or the risk ratio in both of these studies, 0.83, 0.84. If you think back to the traumatic hemorrhage data with tranexamic acid, the risk reduction or the hazard ratio was about 0.8. So very consistent results, not only in multi-center studies with trauma patients, but also with obstetric hemorrhage. So I think there's certainly a benefit and a consistent benefit with early tranexamic acid in bleeding when we know when the bleeding has occurred. So where are we going from here? And I think there are a lot of questions that are to be asked, especially when it comes to hemorrhage. And I think this is some of the exciting areas, especially for research, that might change our practice. I didn't talk about whole blood, and I could spend another hour, 2 hours talking about whole blood. I'm sure many of y'all are using whole blood as it's becoming a lot more common in trauma centers. We're not quite sure where the benefit specifically in whole blood is, yet there seems to be some benefits, certainly with ease of use. Yet what are the benefits of the ratios of whole blood and plasma? What about cryoprecipitate in plasma? We didn't talk about coagulopathy, and that's a whole other topic. Yet we know that coagulopathy is occurring in a number of these patients with hemorrhage. And so how do we treat that coagulopathy and really addressing some of that fibrinogen deficiency, which we know occurs fairly early in bleeding trauma patients? And also, can we use some now artificial intelligence, really large machine learning databases to predict even earlier blood loss than compared to some of our massive transfusion risk scores? And that's something that we're trying to do here is really use a lot of our machine learning data to predict early blood loss, even pre-hospital. And so, as I mentioned, we've got a lot of large retrospective data looking at whole blood. I don't think we have any definitive conclusions on whole blood yet. There are a couple prospective randomized studies looking at this. Where we really don't know is there a benefit of whole blood outside of trauma? And this is becoming a really big and interesting topic just among anesthetists of should we be using more whole blood in intraoperative bleeding outside of trauma? And I honestly don't know. I hope some of our efforts in the next few years work to address that. And as I mentioned, the benefits of early cryoprecipitate in hemorrhage. This deals with a little bit more of the coagulopathy, yet we've also observed that in cryoprecipitate, we have plasma. And what is in that plasma? It's the proteins which might help restore the inside of the blood vessels. And a lot of basic science data is starting to show that cryoprecipitate might help restore the inside of the blood vessels, very similar to plasma. So ultimately, I think our goal with hemorrhage and how to deal with hemorrhage is we talked about, recognizing when it occurs, minimizing crystalloid, getting early plasma and early tranexamic acid. Yet ultimately, the whole goal is to get the right blood products to the right patient at the right time. And I think it's using the data that we have, whether it's clinical data, whether it's vital sign data, whether it's machine learning, artificial intelligence data, will help us get blood products to patients. It seems early plasma is most beneficial in hemorrhage, especially with blunt trauma, maybe a little bit longer transport times. That's actually the reality of most of our trauma centers, is that this is blunt trauma with longer pre-hospital transport times. That's trauma in the United States. We think about traumas being gunshot wounds, stab wounds. Those occur, especially in urban environments, but even us at shock trauma, large trauma center, most of our trauma is still actually blunt trauma. So how can we get the right products to the right patient at the right time? So with that, again, I'm very grateful to get to speak with you all this afternoon. Thank you so much, Dr. Ellis, for inviting me to do this talk. I'll also include my email at the end. If there are any questions that come up outside of this or when you get home or even during this week, please do not hesitate to send me an email. I love hearing about this and discussing it. And so I will say I'm kind of slow to respond to emails sometimes, but please feel free to reach out to me. Here are the polling questions. And so the first question being, and I'm going to try to answer these. Actually, I'll refrain from answering these so as not to give some of it away. I'm going to close out of that. Yeah, what would be your initial choice of resuscitation in a hypotensive patient involved in a motor vehicle collision? Would it be that fresh frozen plasma? Would you give crystalloid? And that might be all that you have is crystalloid. What about early cryoprecipitate? We talked about that a moment ago. Or let's actually not use blood products until we can actually get hemorrhage control because there's a benefit of permissive hypotension. Question 2, when would you want to administer tranexamic acid to a patient with gastrointestinal hemorrhage? Would you want to give them blood products first? Again, early blood product recognition. After viscoelastic testing, we didn't talk specifically about viscoelastic testing. That's becoming commonly used, at least to address coagulopathy in a lot of centers. And there's part of viscoelastic testing which can identify fibrinolysis. So would that be the most opportune time to give it in patients with gastrointestinal hemorrhage? What about cryoprecipitate? There's certainly a benefit, we think, in trauma patients who are getting cryoprecipitate and tranexamic acid. Or would actually you refrain from giving it to this patient? And then last question, at what point would you want to administer vasopressin to a trauma patient? Would you not do
Yeah,
it because
please do answer the questions, the polls here. Let's see what you think. You know, you're not going to get graded on this. No one's going to slap you on your hand if you get what is considered the wrong answer. We want to see what people are thinking.
Yeah. John, are we able to see the results at all?
Let me end the poll here. There's just a few more votes here. And we got here again, initial choice for resuscitation, TXA.
You ended it?
I'm talking. And when would you give vasopressin? And now we will end the poll. And we will share the results. Can you see those, Justin?
I can, yes, sir. So wonderful. The first question, as far as most people were answering after they would use fresh frozen plasma as the initial resuscitation. And I would agree. I think that's what the the Pamper trial showed. That was the early plasma on a helicopter. Majority of those patients were blunt trauma, like a motor vehicle collision. Now, I'll also kind of give a shout out to those people who may have answered the bottom one of I would not use blood products in favor of permissive hypotension. I think the reality for a lot of people is you might not have anything, or you might have crystalloid. And to those folks who answered crystalloid, certainly recognize that if you don't have anything other than crystalloid, it's very tempting to do that. Um, I I work at a place that has very early blood products. Yet I certainly appreciate the very tempting idea. If we don't have anything, let's give crystalloid. What I would say is I think we should try and minimize crystalloid as much as possible. The more crystalloid we give, the worse we know the outcomes are. And if all you have is crystalloid, certainly the patient's going to do what they want to do. And if they're hypotensive, that's permissive hypotension. Yet I think it's better than crystalloid. Um, Question number two, as far as tranexamic acid with gastrointestinal hemorrhage, interesting that a lot of folks would give it after the 4 units of red blood cells. Another about proportion, 25% would do it after a viscoelastic test, and less than 20% would not give it. The answer I gave is correct, is I would not give TXA in this patient, mainly because of the prospective study that we have showing that TXA in patients with a GI hemorrhage didn't decrease mortality and increase the thrombotic risk. And I say this because I wouldn't give it that I don't know when the bleeding started. Every time I'm giving tranexamic acid, I'm thinking, have we done this as early as possible? And if we're outside of a 3 hour window from the time of when bleeding started, I'm very, very, very hesitant to give tranexamic acid. I can't say that it's wrong to do. Um, Yet I don't think the data supports routine tranexamic acid in patients with gastrointestinal hemorrhage. Again, I think the limitation is we don't know when the bleeding actually started. And the last question, at what point would you administer vasopressin? A majority of folks answering during a massive transfusion, the patient remains hypotensive. Um, Interesting. I threw the third one in there of norepinephrine dose exceeding zero point 0.2 micrograms per kilogram per minute. I think that's an attractive answer. Yet that's more so of how we are managing vasopressin with sepsis and septic shock. And so I emphasize the early vasopressin in patients with massive resuscitation because that's what the prospective randomized studies have shown. And that's kind of my go-to of if I'm choosing a vasopressor in patients with ongoing hemorrhage, it's going to be vasopressin with blood products. And that's where I emphasize, and I think the important part to this answer is during a massive transfusion and they're getting blood products. I would not favor vasopressin without blood products.
Great. So I'm going to go to a couple of questions in the chat, but for me, it reminds me of a humorous anecdote in my life. I was on a flight sitting next to the chairman of surgery at University of California, Irvine. At the University of Chicago, where I worked for a couple of decades, on the south side of Chicago, kind of like Baltimore, but we didn't have people helicoptering in from far and wide. So most of what we saw was penetrating trauma. And the University of Chicago closed their trauma unit in part because it was a big money loser. And we were talking about that. He said, oh, well, in Orange County, trauma is Mercedes versus Lexus. It's a big money maker for us. Going to the questions here, can any of this be extrapolated to large blood loss in aortic dissections? And I would add to that, that was a question from James. In that setting, I mean, one can choose to provide permissive hypotension, not just permissive hypotension, but potentially active hypotension by using vasodilators. Any thoughts about that? Permissive hypotension, aortic dissection, and using vasodilators to produce hypotension.
Yeah, I'll say, John, I apologize if you've lost my video. I had a problem with my phone camera a few moments ago. So if you don't see my video, that is why, and I apologize. Yet to answer that question, as far as aortic dissection, now I'll specify in an aortic dissection, I would treat the aortic dissection, which is what we know of impulse control, heart rate and blood pressure control, until that dissection is managed. And that is the kind of the concept in and of itself. So to the question of would I use vasopressors and vasopressin in those patients? No, not necessarily. Would I want to use balanced blood product resuscitation with early plasma? If they're bleeding, yes. But usually with aortic dissections, we're not so much worried about the bleeding. I'm worried about maintaining the hemodynamics to not cause worsening dissection or rupture. Now, I'll also add another piece to that of a lot of what we've extrapolated initially to trauma hemorrhage actually came from vascular surgery in aortic aneurysms, where we've got the risk of rupture or aortic aneurysms that have ruptured. And a lot of our initial practice in permissive hypotension was actually extrapolated from a vascular surgeon's case series on aortic aneurysms. And we kind of followed this case series and the dogma of this case series to think that aortic aneurysm rupture was the same as traumatic hemorrhage. And there's some similarities, yet it was still a case series and not prospective randomized data. So the simple answer to the dissection is I would treat the dissection. Ruptured aortic aneurysm, I'm treating that like bleeding and wanting to get hemorrhage control, but get blood products. And vasopressin if they're hypotensive, yes, and they're bleeding. But that's
Yeah. And then again, looking at the chat here, Lee asks, what's the role for colloid, i.e. albumin? And then there's a separate question. I don't know if you see the chat, the role of tranexamic acid versus Amicar aortic surgery, i.e. roots.
Yes, so colloid, same as crystalloid. I would stay away from colloid. There's certainly a harm of colloid in traumatic brain injury. Most of our trauma patients, blunt mechanism, high risk of traumatic brain injury, and we know that albumin and colloid increases mortality. And similar to crystalloid, is not providing the proteins, it's not providing the oxygen carrying capacity, it's not the same as plasma. So I try and really stay away from uh, colloid and albumin with active hemorrhage. In the role of TXA or Amicar in aortic surgery, and this is, and I'm going to say I don't do much actually cardiac. I'm going to say here's kind of how I've learned a lot about coagulation from the cardiac folks. Is I think there's benefit. And as a trainee, we would kind of do this from the start, similar to the way we would do a lot of liver transplants in patients who we thought were going to be really high risk of bleeding, is we're starting that infusion from the beginning of the operation. And that's where I think there's likely going to be benefit. I just don't know in which patients. I think if you got a high risk of bleeding, yes, because now you know when the bleeding has actually started, i.e. cardiopulmonary bypass, and coming off a cardiopulmonary bypass. And there's the benefit of your antifibrinolytics. That's certainly from a TXA standpoint. I'll be honest, I don't have any experience using Amicar. We don't use that in trauma. It's specifically tranexamic acid. But I'll reemphasize, I think any benefit outside of trauma is going to be you're starting these antifibrinolytics either at the time of bleeding or before bleeding has started. That's why the orthopedists are actually so good with tranexamic acid, is because they're giving it at the very start of the operation.
All righty. So Andy Leibowitz, who's made it down from New York and Mount Sinai, is actually going to give a talk about fluid resuscitation as well tomorrow. So we'll hear the yin and the yang of choice of fluids in different situations. So Justin, I want to thank you so much for spending the afternoon with us. And does anyone else have any other questions for Justin before? And you can come on. Can we, if anyone wants to actually ask a question, can we unmute them, Tracy, if we need to? Yeah, so does anyone want to speak up before we get a thank you? Dawn Springer says thank you with an exclamation mark. That must mean it was good content.
Oh,
Anybody else? All right, Justin. So we're going to go from quite hairy stuff. Let's see. We got Donna Costello says great talk. We got some thumbs up and some claps here. So, you know, if I have my car accident or God forbid whatever else, you know, I want it to happen in Baltimore and I want to be helicoptered into Justin's OR. All right, so we're gonna
thank you so much, John.
Yeah, so we're gonna switch over to Natalie Barnett, who's going to talk about pediatric premedication, perhaps a more joyous thing to talk about. Natalie, are you there? Can we give you let you screen share? And maybe what we'll do is we'll get her set up and we'll kind of I'm going to take a 2-minute bio break, and maybe everybody else can do that. And we'll be back here in 2 minutes by the clock. How about that?
Before you run away, are you able to see my presentation?
I see you and I see your slides.
Perfect.
Be right back. All right. Well, I am back. This is the start of the Mount Sinai takeover. Last year we had Jonathan Gall come down from Mount Sinai and joined us. And this year we have two of the current faculty at Mount Sinai and two alumni. And so, that's all good. We can learn how to say coffee and things like that, from our colleagues from New York City. So Natalie can tell us about her background because she's now at the Medical University of South Carolina. She's going to talk about pediatric premedication. And take it away, please, Natalie.
Hi, I'm Natalie Barnett. I am a former Mount Sinai resident as well as Mount Sinai faculty in another life. I am in Charleston, South Carolina at MUSC. I'm primarily pediatric anesthesia. So I tried to format this talk to be a little more applicable to a wide variety of listeners because I know that not everyone is in a freestanding pediatric hospital and practicing 100% peds. So hopefully this can resonate with some of those of you who are in mixed practice and see our healthy kiddos, or even the older ones who grow up and still need pediatric touches, such as those with developmental delays, autism spectrum disorder, etc. So I am going to talk to you about preoperative tips and tricks to help minimize perioperative anxiety in the pediatric patient. I have no financial, academic, or other disclosures. For my goals and objectives, I want to make sure that at the end of this presentation, you are all able to describe the preoperative considerations unique to the pediatric patient, including common triggers of heightened anxiety, consequences of perioperative anxiety, the approach and tricks for preparation techniques based upon developmental age and stage. Additionally, you will be able to identify strategies for the mitigation of preoperative anxiety, which include premedication, parental presence at induction, which I'll probably refer to as PPI as we go through the presentation, as well as various distraction techniques. So why do we care and what are considerations for a smooth preoperative experience for the pediatric patient? The improper handling can lead to short and long-term consequences for both the child and the family, whereas proper handling can improve the entire perioperative experience and can aid in establishing a positive trust with medical staff. In general, the most common trigger of anxiety in kids are parental separation, fear of the unknown, and pain. When considering anxiety, there is a state versus trait. For pediatric anxiety, state is the temporal situation and is related to a specific situation, such as a operative procedure, going to the doctor, going to school, etc. In contrast, trait anxiety is inherent to the child and their personality. So between both state and trait anxiety, it's highly prevalent in the pediatric population and is likely greater than 60 to 75%, depending on which source or literature you're looking at. Additional factors that contribute to emotional distress can include lack of familiarity with the surgical setting, such as the medical equipment and supplies that they'll interact with on the day of the procedure, lack of preparation for painful procedures like IV placement, and inadequate preoperative information for both the family and the child. Patient factors that are associated more highly anxious kids, those are going to be pediatric patients that may be more likely to have things such as younger age, inhibited or shy temperament, repeated hospitalizations, prior traumatic experiences. They don't even have to be necessarily operative, but those could include prior doctor's appointments blood draws, ER visits, and or cognitive behavioral conditions that can decrease the ability to communicate and or lead to difficulties with cooperation, things such as developmental delays, Down syndrome, autism spectrum disorder. So what's so scary about the operating room? Well, this is what you see as you're walking back or riding back in a stretcher. A lot of equipment in the hallways, usually not super bright or compact, crowded hallways. And then you're in the room and you're forced to have parental separation and a mask induction. Poor mask acceptance for mask induction is most common in the toddler group. But as one can imagine, being a small child laying on an operating room table and seeing people in hats and masks with bright lights and surgical equipment can be pretty anxiety provoking. Why do we care about preoperative anxiety? It's just a little bit of the scaries, right? Well, actually, there are pretty profound ramifications of anxiety. It can lead to short and long-term complications. It can be a longer and more difficult with trauma associated with a mask induction, which could include breath holding and a higher risk of laryngospasm. And given the fact that most mask inductions are done without an IV in place, that can be difficult to control at times. And there may be increased perioperative pain, as well as more significant emergence delirium and postoperative distress. Once home, the child may experience insomnia, increased bedwetting, poor appetite, and negative behavior changes, or even behavior regressions, and avoidance of future health care. So that can last long into adulthood, in fact. So how can we help decrease this anxiety and help prevent these long-term ramifications that can be associated? So here's my first question. What is the most used method to alleviate pediatric preoperative anxiety at your institution?
So I've launched the poll, folks. Please do respond.
Seems pretty evenly split so far. I'll give it we're almost half of participants answered.
So while people are finishing voting, I'm going to tell a terrible story about the few times I would do pediatric anesthesia for kids who were about maybe 4 to 8 years old. I would just say, you know what? I got $5 here. Depended on the kid, you know. And I'm gonna give grandma this $5, and if you go in and blow up the balloon, you'll have $5 to buy ice cream and candy with afterwards. Now, some people told me that was quite unethical, but it seemed to work for me.
You know, sometimes you just got to do what you got to do. So it seems pre-medications are the more common, followed equally by distraction and PPI. Okay, so let's see. So there are both invasive and non-invasive strategies for decreasing preoperative anxiety in pediatric patients. These are tactics to prepare the child based on age and developmental stage, such as therapeutic play or videos. Additional options can include premedication, distraction techniques, and PPI. Of note, parental anxiety is a predictor of patient anxiety, and reducing parental anxiety may be an important target for reducing pediatric patient anxiety. Factors that can contribute to parental anxiety include separation from child, lack of control, and potential risk or complications from the surgery itself. Strategies to decrease parental anxiety include preoperative education, specifically video-based education materials or programs, and therapeutic play alongside their children, PPI and integrative preparation programs such as a hospital tour that both parent and child can attend prior to their procedure. This is preparation based upon developmental stage and age. It is pretty busy, but I think that it is helpful to differentiate between the different ages of children, because an infant is going to be much different than a teenager and preparing them for surgery. So clear preoperative information has been demonstrated to decrease anxiety in children and in parents. It can mitigate negative behavior in children and enhance parental satisfaction. Education is key, and you must pay attention to the developmental stage of the child. This is not always going to correlate with their numeric age. In general, play is essential in the monitoring of a child's emotional, social, and cognitive well-being. Any perioperative team member can utilize play to try to help comfort children. So that can be anyone from medical students to nurses to residents and physicians, and anyone who comes into contact with these kiddos. For infants, it's important to maintain the routine. You can minimize environmental stimuli, which means darkening the room, maybe having the comforting lullaby music or a blanket pacifier, and really just snuggling with the loved ones, whether that's a parent or a caregiver. As you move into the toddler preschool age group, it's more helpful to, think about it in the sense of not giving them too much time to think ahead and dwell on the procedure. They do better if you tell them a short period before they're going, use simple language, like saying things along the lines of, we're going to see your doctor, where you'll take a nap, and he or she will fix what's been hurting you. You'll wake up safely and we'll be with you. Keeping it as simple and concrete as possible. And medical play can also help identify any sort of misconceptions that the child might have. You really want to make sure that they don't think it's their fault, or they're being punished in any way. As you get to the older school age children, so thinking more elementary age, 1 week before the procedure should be adequate. Again, concrete language explaining the benefits of the surgery. Your ankle has been hurting you since you broke it. Now we're going to help your ankle heal so that it's in a better state for the rest of your life. Kids in this age group tend to be very scared of the safety of a procedure and making sure that they're going to wake up at the end of it, and being able to prepare for the specific experiences, whether that is the mask induction or if it's an IV placement, what type of pain to expect and confusion. And maximizing control can be anything from picking what song you want to listen to during the induction. If you're able to put on a movie on the big screens in the operating room, you can do that. And letting them bring back their favorite stuffed animal or blanket or book can also be of help. Teenagers and preteens process better with the most amount of time to allow them to go through the emotions. And usually you want them to feel as though they have as much involvement in the process as possible. So letting them come up with a list of questions for the doctors and nurses, letting them interact as much or as little. Some teenagers may just want to put headphones on and watch TikTok, and that's okay. That's how they're going to process it. And emphasizing that they will wake up at the end of the procedure. Starting with premedications, these are obviously well recognized in the ability to decrease preoperative anxiety, not only in kids, but all age groups. I mean, most adult patients get the 2 of Versed and maybe some dexmedetomidine rolling into the operating room and just to take off the edge. So not just isolated to our kiddos here. Goals of an ideal pre-medication are medications that can reduce anxiety in the child, allow for calm separation from the parent or caregiver, facilitate smooth induction of anesthesia, which typically is acceptance of a mask induction, and reduce post-operative psychological trauma. Unfortunately, it can sometimes be hard to find the happy medium here. Kids tend to either be over-medicated or under-sedated when they come into the operating room. So pre-medication can sometimes not be the 100% fix for this. More Characteristics of an ideal premedication are going to be those that have a rapid onset, are short acting, simple to administer, and easily accepted by the child. Those are not necessarily going to go hand in hand. Some medications are very easy to administer, but kids will freak out and scream, such as nasal midazolam. Have minimal side effects because you are going to start mixing in a general anesthetic, but supplementing the general anesthetic can also be helpful with the analgesic properties. So here is another question just to kind of see what those of you on the call would do for this patient. He's a 17-year-old male, 110 kilos, autism spectrum disorder, attention deficit disorder, global developmental delay, minimally verbal, and moderate sleep apnea. He's coming in for dental examination and possible restorations and extractions. What would your pre-medication choice be here? All right. So, well, it keeps closing out on me.
A few people voted here.
Some people voted. So mixture of oral midazolam. So a little bit of everything, it looks like. So we can revisit this once we go through the pre-medications. This keeps popping up. Okay.
I'm sorry. So you see it here now, right? You're good? We can proceed?
Yeah, I think we can move on. It looks like most people are either picking midazolam with ketamine or intranasal dexmedetomidine. Okay, I'm going to move on. So midazolam, this is the most common pre-medication, I think, both in pediatric and other patient populations because of its sedative, anxiolytic, hypnotic, and amnestic effects. It is a benzodiazepine with action at the GABA A receptors. It is fast acting with a short elimination half-life. And you also have the ability to reverse it with flumazenil. It can be given intranasally, orally, intramuscularly, or intravenously. Intranasally administration is typically met with an unhappy child due to the nasal irritation, burning cessation. Usually these kiddos will scream their head off after getting it. So that can be somewhat disconcerting for a parent. So good preparation for nasal midazolam should be provided to the parents to prevent kind of that shocking response. It causes anterograde amnesia and may maintain implicit memory for a potentially stressful perioperative event. So that can induce a scarce explicit memory for the same event. So these kids can unconsciously remember stressful events without the ability to pull them consciously back to mind or elaborate on what had happened. So this can sometimes lead to potential downstream effects from that aspect, as well as the risk of paradoxical reaction to midazolam, which is characterized by psychomotor, restlessness, and agitation. Usually these kids will have some sort of an history of having a paradoxical reaction, whether it be to diphenhydramine or other medications similar to that. Ketamine is another commonly thought of medication when thinking about pre-medication for children. It is a dissociative anesthetic. It's a phenylcyclidine derivative and an NMDA antagonist. It can be given orally, intramuscularly, or intravenously. It causes the dissociative anesthetic, which is characterized by a functional association between the thalamus and the limbic cortex. So the patient may appear conscious, but is unable to process or respond to events going on around them. This is also something that parents should be prepared for because of the eye movements, the nystagmus, and the possible increased salivation and hallucinations. So, these kids can sometimes appear very disoriented, and parents can be thrown off a little bit by it. because they can be described as I've seen it described as a dull doll. So kind of like the lifeless doll, due to the dissociative anesthesia. And it can also stimulate endogenous catecholamines and result in significant nausea, vomiting. Dexmedetomidine is a new player on the block. It's an alpha-2 adrenergic agonist. It can have a relatively longer onset of action in comparison to ketamine and midazolam. So that's something to keep in mind, especially if you're worried about a fast turnover situation at your institution, because it can take quite a while, upwards of 30 minutes to kick in. And it is associated with minimization of emergence delirium, which can be hugely helpful for these pediatric patients with flow of the OR, because it can help decrease PACU time and wake up. Giving it orally has been discussed, but it is questionable given its high first pass effect and poor oral bioavailability. But there are some studies that have suggested sedation effect when you're giving it in the higher dose of the 4 mics per kilo. So which medication is best? This is just a quick PubMed search that I did in preparation for this particular slide. These are, you get 700 results when you type in pediatric premedication. It's just, there's every possible combination of this versus that. And it's hard to really tell what is best. So I think what needs to be considered when you're comparing these is really what the kid needs and how well the kid is going to respond to the various ability to give it orally, intramuscularly, or intravenously. When you're looking at these medications, midazolam is historically the most common premedication because of its fast onset and relatively short duration. Usually it's pretty well tolerated orally if you mix it with syrup to make it sweeter, or Sprite, or offering a small sip of water afterwards, but it does have quite a bitter taste. So often the strategy is to get it in as quickly as possible. I have found anecdotally that if you give the either Tylenol, acetaminophen, alongside the midazolam, it is better taken because kids tend to be used to taking oral medication, whether that be ibuprofen or acetaminophen. Historically, like I said, when it's given nasally, it is definitely met with some combativeness. And there is the chance, no matter how you give it, to have the potential paradoxical reaction and potentially increasing your emergence delirium. Ketamine is a common choice for an uncooperative child or a large child because you're not necessarily bound by hard and fast dosaging, because for midazolam, most will only give 20 milligrams due to the volume that it would put in the stomach. So if you have the 110 kilo patient and you only give 20 milligrams, that's vastly underdosing when you're looking at the 0.5 milligram per kilogram dosing parameters. With ketamine, however, you can give it and you can get the concentrated 100 milligram per ml dosing, or the concentration of 100 milligrams per ml, and you can combine that with the midazolam and a little bit of sweetened syrup, and you can get benefit from both medications, and it is still going to be pretty quick in onset. Dexmedetomidine has a much longer time to onset when comparing to the midazolam and ketamine, but similar to ketamine, you have more wiggle room with the dosing parameters, with the caveat being once you start getting to be more than 1 ml or so per nostril, per nair, you worry about the actual absorption intranasally, and you may be getting more later effect from the oral runoff in the nasopharynx. Oral formulations are oftentimes the best accepted by the child, but they may not be as efficacious at the time of mask induction just because you're often limited by dosing parameters. And like I discussed, you must also consider the volume you're giving when giving intranasally. And when you're looking at the child, usually discussing with family what route of pre-medication will be best tolerated and accepted by the child may help you when deciding what medication to use. Because if they're not going to take anything by mouth, they're not going to let you get close to them with intranasal formulation, whether that be dexmedetomidine or midazolam, you may be looking at a ketamine intramuscular pre-medication, as that is very easy to facilitate because it is so fast and you're able to get that medication into them. There is a little side note I want to make here, which is clonidine. It's also an alpha-2 adrenergic agonist, and it can be effective for behaviorally challenged pediatric patients when you give it at home. But it hasn't been super well studied. There's been quite a few case series published where it can help get the child just into the hospital, because you can have very large developmentally delayed autism spectrum disorder patients who can be aggressive and combative, and they know when they pull up to that hospital, they don't want to go in. So, and oftentimes they are on quite high doses of medications that are in the benzodiazepine class, and being able to give them Valium, one-time dose of Valium or diazepam may not be sufficient. So being able to work in clonidine can be helpful because you're less concerned for the respiratory depression that you might see with higher doses of benzodiazepines. So I guess when we're thinking about that patient, the 110 kilo male for dental procedures with significant developmental and global delay, typically I would discuss with the parents what they're used to as far as medications go at home. There are some kids that are very used to getting nasal sprays for either seasonal allergies or sleep apnea. And so they're used to that and they'll tolerate it, in which case I would advocate for dexmedetomidine intranasally, especially given that's potential to decrease emergence delirium, which will help you on the back end of the procedure. But if you're not going to be able to get close to them for the nasal, you've reached your max dose with your oral midazolam. So then you're left with either a mixture of oral midazolam and ketamine, or a ketamine intramuscular. That would be my strategy. And if I knew about it in advance, I would try to give the parent a call beforehand to see what they would recommend, just to be ready for it. That's not always feasible, but it is always an option. So next is PPI. This can provide a more compassionate and individualized approach to pediatric anesthesia through the respect of parent and child bond as a family unit. I found this quote in the opinion survey from Osterberg and Anderson, looking at the staff and within an anesthesia department. The very enlightening, which is parents are expected to step up and provide support to the child while also maintaining control. However, the parent is also expected to step back, stay out of the way, and give room for caregivers' expertise. So it leads to a situation where there's constant flip-flopping back and forth between trust and distrust with the parent and the anesthesia team during a mask induction and the preoperative experience. For PPI, it's highly dependent on the institutional policy and culture at each individual hospital. However, it is most common that one parent or caregiver is able to accompany the child to the operating room and be present for parental presence or for the induction of anesthesia. PPI may or may not be combined with other strategies. You can use distraction, whether it's on your own iPad or iPhone, or you may have the luxury of having child life in your institution who can come and play games, read books, or even sometimes you can get cartoons on the overhead screens in the operating room, and having both the distraction and a parent can be incredibly useful and is better than one technique by itself. But it does require appropriate preoperative education and counseling for the families to make sure they know what to expect and how to be of best assistance. So when you're thinking about it, what are the pros for PPI? It respects the bond between parent and child, and parents largely feel that their presence was beneficial to the child, even if it does not alleviate or even worsens their own anxiety. Most parents who have participated, they often state that they would like to participate in a future procedure as well. PPI is strongest when combined with other techniques or pharmacological interventions such as premedication, and allowing the child to choose the accompanying parent may lead to a decrease in perioperative anxiety. And we have certainly seen that it increases parental satisfaction. Cons, of which there are many. With all things like medicine, there's another side to the same coin. Arguments against PPI include that the simple presence of parents and caregivers may not reduce anxiety if proper preparation and communication are lacking. It can lead to tension in the operating room and can distract the OR team from their primary focus, which is the child. There is often variable attitude and receptiveness amongst the operating room staff. The provider attitude may improve with experience and positive exposure to PPI. So the distraction techniques that I'm talking about, when welcoming children to a hospital or ambulatory center, there should be child-friendly interior design and waiting areas. It's even if you're not in a freestanding hospital, children's hospital, there are ways to make it more welcoming for a child. And that comes with recognizing that play is incredibly important for children. So having playrooms or areas with kid-friendly activities can set the stage for a less anxiety-provoking environment. It becomes less sterile and more fun. With this in mind, distraction techniques are the most common non-pharmacological or non-invasive therapies to minimize anxiety. They can be active or passive. Active distraction seems to be more effective and includes things like video games, bubble blowing, playing games, ball squeezing, coloring, or other arts and crafts. Child life specialists are members of the perioperative team that are also trained to assist children and their families and how to cope with medical events. And they are important patient advocates. And they are often trained in psychosocial developmental of children and can help tailor the distraction technique to each special child. They are very skilled in calming and comforting distressed children, and they hold an essential role in the perioperative process. Child life specialists have a lot of tools in their armamentarium, but one of the best is play. Therapeutic play has been shown to be hugely influential and helpful for alleviating pre-op anxiety, and can include strategies like mask preconditioning, whether that's videos that they can show children or just playing with them in the preoperative holding area. And Jacob et al. In their study recently showed that especially made video is not necessarily better than preoperative play in the holding area when looking at mask acceptance into the induction. Interactions with child life has been shown to decrease patients' anxiety level and increase patients' rapport with the staff, and can help correct misconceptions of the medical environment and empower children to be self-sufficient by encouraging autonomy. You may see child life and their involvement with hosting tours in the procedural area, providing developmentally appropriate education materials, and meeting with families to discuss individualized coping plans for the day of surgery. Audio visual distraction is certainly one technique that everyone is familiar with. Everyone has it in their pocket. And even kids as super young know how to work iPads and iPhones. And it can offer a non-pharmacological alternative to preoperative anxiety management. Two-dimensional video is much cheaper and easier access than thinking about 3D immersive virtual reality. And it's also very customizable. Kids can pick whether they play a game or they watch a movie, cartoon, or they have coloring apps where you can color different things. And there's been many studies looking at midazolam with or without distraction with video, and there's differing findings, but oftentimes there's not a huge significant difference. 3D virtual reality is computer technology that creates a 3D simulated audio and visual environment. This can be immersive or non-immersive. For immersive, that's what this cartoon is showing. With the goggles, you can fully go into a different world and be able to completely block out the environment. Or you can look at a 3D simulated environment without the goggles. And so that may be better accepted for children with higher anxiety and the inability to participate in the immersive experience. Through a systematic review and meta-analysis, Simonetti et al. Found evidence to support the effectiveness of virtual reality in reducing pediatric anxiety in patients undergoing surgery looking at anxiety scores. They did not identify a difference in respect to emergence delirium, however, or any sort of later maladaptive behavior changes. In a randomized controlled study by Carbo et al., they found a virtual reality education program was associated with lower anxiety scores during parental separation and before the entry to the operating room. They were also more cooperative with mask induction with the immersive virtual reality program. And this is looking at the study by Sam Nakayan et al. And it was looking at 3D immersive virtual reality compared to typical two-dimensional distraction technique and the potential benefits for managing pediatric anxiety. The same video was used and adapted by SmileyScope, which is a virtual reality device for either 3D or 2D on an iPad. There was no difference, however, in the anxiety scores when looked at change in anxiety from the preoperative holding area to the induction. Both groups had smaller increases when moving from pre-op to OR, which suggests that both methods are reliable for anxiety reduction. Children and their parents both rated the 3D and 2D highly. However, the anesthesiologist preferred 2D to 3D based on simply the interference that you get with the goggles for mask induction, as well as not being able to really see the eyes during induction, which can limit your ability to tailor the mask induction and be able to time getting parents out of the room and whatnot. I've found the socially assistive robots to be super interesting, while maybe not super accessible to all across the country and around the world, because they are quite expensive and can range in price to upwards of $80,000 per unit. But they are very interesting in the fact that they've been transitioned from working on a factory assembly line to now these socially assistive robots. They can be designed to specifically interact with children. And they can do things like help talk them through what to expect. They can play favorite songs. They can greet them by name. And it helps kids feel a sense of companionship and connection. And they can mimic human behavior. So sometimes they can even reach kids who are hesitant or resistant to traditional human interaction, such as autism spectrum or developmental delays. The benefits to these robots is they can decrease pre-procedural fear, as well as procedural fear, such as getting an IV placed or a vaccination. And like I said, they can help prepare children for the procedure experience and mask induction, and even accompany a patient to the operating room, and can lead to lower anxiety scores at induction. There's been quite a few studies coming out of Alberta Children's Hospital. The Child Life Department began using these socially assistive robots to provide friendly distraction, commiserate with the patient by talking about experiences with the same procedure, and teach breathing techniques during vaccination and venipuncture. The children who interacted with these robots seemed happier during the procedures and showed a decrease in pre-procedural and procedural fear. There's also been some studies coming out of Italy, and those were either using a robot or not using a robot, and the children's anxiety was scored at the time of premedication as well as the time of induction. And the children who had the robot accompany them were shown to have lower anxiety scores across all time points. And transitioning to another form of distraction, which is not necessarily as popular in America, but it is very popular worldwide, and that is using clowns, and they're sometimes referred to as clown doctors. And everyone has heard the saying that laughter is the best medicine. And these clown doctors incorporate that into all of their interactions with patients. They recognize the importance of incorporating laughter and play into clinical practice. Patch Adams is one of the pioneers in therapeutic clowning, and he's one of the most well-known, especially based on the movie that was made about him. They're typically professionally trained, highly adaptive, and can manipulate the experience based on the patient and the family or anyone else who is in the room. Have to also consider, I don't want to butcher this word, but coulrophobia, which is the fear of clowns, though its incidence is not well studied in kids or in adults. A recent study estimated about 1.2% of children in a hospital setting were frightened of clowns, with most commonly being in the toddler age group and female. This was a very large systematic review of 24 studies encompassing just a little over 1,600 children and adolescents in 9 countries. The authors found that clowning is associated with a decrease in anxiety. It can improve psychological well-being and emotional responses in pediatric patients for both acute and chronic conditions, and can increase cooperation with medical exams. And can help reduce distress in parents and members of the healthcare team. It's most commonly studied in surgery and ICU care, and looking at anxiety and pain management. So in summary, I really hope that I was able to give a broad look at how to help decrease anxiety for our kids that either come to a children's hospital or a community practice. Combine psychological support with such as PPI or Child Life and distraction techniques may be more beneficial than either in isolation. And pre-med plus non-pharmacological intervention may significantly improve outcomes. Distraction techniques help. There are so many different ways to distract kids, and it's highly accessible and easy for across the board. And these are all my references.
Well, thank you so much. And we got a couple of questions in the chat, Dr. Barnett. First, we'll get to Andy Bishop's comments and questions and then to mine. And other people may jump in as well. I noted that I said, I know some clown doctors for sure with a smiley face, and a couple of people ratified that, although I don't think those are the kind of clown doctors that you were talking about. Andy says, I find that distraction techniques, bubbles, encouraging the 8 to 12-year-old kids to be brave, taking time to sit with them often works. Not talking about the autistic or the developmentally delayed with violent tendencies. I always involve those parents in making the choices for their kids while ensuring the safety of myself and staff. I have allowed those parents to go in the room until induction was over. I told them they would be escorted out before any surgery begins per policy. Thoughts, questions, comments about that for you, Dr. Barnett?
I'm sorry, I didn't hear a question in there. I just heard that talking to
Yeah,
children.
do you have any comments or either questions in hearing that you might ask for Andy Bishop, who posed that comment?
No, I mean, I think that's incredibly valid. You know, I think setting expectations and listening to parents or caregivers is probably your best secret technique. You know, parents often know what works for their children, and sometimes they may take a little bit of coaxing because parents can also be stressed and anxious, and figuring out how to get the information from the parent and from the child is a hugely valuable strategy. And as long as parents understand that they can't stay for the whole time.
So that leads to something I put in there. So, I once had a parent who, understood that she was supposed to leave, and we're in GI. So it's like, and she's like, well, no, I don't want to leave. And well, you got to leave. Well, I've watched this on Discovery or whatever. In general, I want to hear about, you're doing this every day. What challenges have you had in the past couple of months? I mean, okay, we see the literature, but like, what challenges in preparation, pre-medication have you had recently, and how have you handled them?
So we have a great child life group at our institution. So we don't really run into the parents who refuse to leave the room. Sometimes it takes coaxing. And multiple people kind of stepping in and saying, it's time to go, it's time to go. I'd say the more difficult piece is figuring out which pre-medication for which child. And that can come from asking family, from even asking kids. I honestly have found recently that in that initial age group that was mentioned by one of the attendants in the chat, that school-aged kids sometimes might actually pick getting an IV. Instead of a mask induction and instead of taking pre-medication. And I will talk them through it and work with Child Life or nursing to get EMLA cream. But I usually take the approach that I'm not going to poke around in a kid who looks like they're going to be difficult access. But if I can see easily accessible veins, kids will respond better to an IV medication because it doesn't hurt. And I still let parents come into the operating room. And I tell them when the sleepy medicine comes, they may pull their hand or foot because it can irritate the vein, but we can usually get a pre-medication in beforehand, whether that be dexmedetomidine or midazolam, to minimize the reaction to it.
So how often are you using EMLA? And I guess this is sort of an ignorant question on my part. How many kids, even though it may not hurt, just seeing the needle and needle phobia, and kind of what age groups are you tending to use EMLA in?
So a kid who's amenable to an IV, and that's usually going to be starting around kindergarten, the 5, 6, and then up. But I'm not going to try it with a significantly delayed child or a kid who you look at their arms and hands and you don't see anything. If they're not.
So are you using on a daily basis? Are you waiting for kids and parents to ask for it? How do you make that decision?
Usually Child Life or the pre-op nurse will say they won't even look at the mask. Like they won't touch it. They won't play with it. And I get alerted that way. So it's
a secondary choice. It's not a go-to for you.
Right.
Okay,
It's
fair
those
enough.
for those kids who don't seem super excited about a mask induction, and they don't want to take a pre-med, but they are anxious.
Okay, so it's sort of kind of it's kind of default, the last choice, and what would you say, that's 10% of your practice?
Yeah, I would say so. And I feel like it comes in waves, where all of a sudden I just a couple weeks ago I had so many kids who were like, I don't want the mask. And so you go through the other options with them. And we're being able to talk that through with them and the parent. But I'd say the hardest patient population is the teenage, over 100 kilo, developmentally delayed kids who come in. They can have a lot of fear.
Right. And how often are you using that ketamine dart these days?
I'd say that's practitioner dependent. I hate is a strong word. I strongly dislike using ketamine darts in large kids who are having short procedures because it hangs around for so long. And usually, like if they're coming for an EGD or they're coming for 2 wisdom teeth extraction, that is a very short procedure. And if you're giving them 500 milligrams of a intramuscular injection because they're 150 kilos, that's going to hang around and they're going to sit in the PACU for a very long time. And I've had families come in with parents saying that their child had horrible hallucinations that they remembered from ketamine. So I really try to get, in those cases, nasal dexmedetomidine and recognize that I may delay the OR start.
And seizure meds, I mean, I think you kind of touched on kids who are induced. Just sort of dose adjustment in kids on seizure meds.
For which medication, ketamine or dexmedetomidine or midazolam?
Or pre-medication, but I guess particularly midazolam, but in general.
I usually, if the seizures are well controlled and they took their seizure meds the day of surgery, which they're supposed to, I mean, midazolam can be used to break a seizure. So oftentimes, I don't adjust too much.
So no concerns, or not much concern in terms of tolerance and needing higher doses.
Well, for kids that are on clonazepam, long term, they're probably not they're gonna be large enough to not even be within the dosing realm of a 20 milligram dose of Versa or midazolam.
Okay, fair enough. Any other questions from the audience? Well, if not, we look forward to seeing everybody tomorrow morning. First lecture is at 7:30 a.m. and continental breakfast will be before that, continental breakfast for attendees. Again, we have recorded this, so if you want to go back to this, this will eventually get posted to YouTube on a private link for folks who registered for the conference to be able to go back and look. Devin says thank you. We look forward to seeing Devin. Devin's one of our perennial attendees who comes from down the street from Mount Sinai, about 40 blocks south, 50 blocks south, and a little bit to the east, HSS. All righty, y'all. Thank you so much. See you all in the morning.
Thank you.
Thank you, Dr. Barnett.
Thanks, John.
Thanks.